Okay, hello, hi. My name is Eleftheria Karino. I would like to welcome you to this winter school, to this first session of the winter school. So, as you know, this normal life continues with this pandemic of COVID-19. And in this framework of normal life, we have the tradition to meet and to have this winter school every year. We are forced now, due to the pandemic, to do this winter school into a totally virtual event, and I hope that we will succeed. So it will take place this afternoon and tomorrow afternoon as well. This year, the winter school will present an overview of the current understanding of the scientific evidence for radiation risk and potential outcomes, including malformation, loss of pregnancy, mental retardation, cancer risks about the unborn child and pregnant patient, the assessment of effective dose and committed effective dose, as well as the protective measures to be mitigated at all development stages from fetus to the pregnant infant will be discussed. Some nice examples from many European countries will be presented, especially tomorrow at the roundtable discussion. So before giving the floor to our first speaker, I would like to remind that there is this Q&A chat where you can use it and pose questions to the speakers. Also, you can see it on the right of your screen. Okay, many instructions will be given afterwards. So welcome you again. Have a nice time with us. So I will give the floor to our first speaker. So Richard, the digital floor is yours.
Yeah, okay, thank you very much. Can you get my slides up there, please? Lovely, thank you. Okay, so I'm going to be speaking to you today about some epidemiology of intrauterine irradiation. It's a big subject. Then Kimberly's going to be coming on next to also talk about other issues concerning in utero irradiation. I'm going to be concentrating on cancer. But just initially, just to remind you, there's apart from stochastic effects, there is also other health effects to take into account from irradiation in utero, conceptus, embryo, and fetus. And these are teratogenic effects, developmental effects, such as congenital malformations and mental retardation, which also have to be taken into account, these specific effects relating to exposure in pregnancy. And as I say, I'm just going to touch on this before moving on to consider cancer. Here's some results from the atomic bomb survivors who are irradiated in utero. And on the left, you can see severe mental retardation in relation to uterine dose received. And on the right, there's the related reduction in IQ, again, with dose. And you can see that for the most sensitive period, 8 to 15 weeks, there's a clear response at higher doses, moderate to high doses, and then less so for the next period of time, 16 to 25 weeks, and essentially nothing outside those two periods. And on the right, the reduction of IQ, of course, is very much related to severe mental retardation. But again, for these two periods of time, it's very difficult to see what might be going on at low doses, but something clearly going on for these two sensitive periods at higher doses. And related to that is the school performance and seizures, unprovoked seizures. Also in the atomic bomb survivors irradiated in utero. And again, of course, this is related to severe mental retardation and reduction in IQ. You can see school performance falling off with dose, particularly in these two sensitive periods, and also seizures occurring at the higher doses. So that's just a quick touch on non-cancer effects. I know that Kimberly's going to be dealing with this as well. So I'm going to move on to cancer following in utero exposure, and my slide seems to have frozen. There we go. It's not moving at the moment, I'm afraid. Okay, right. Okay, it's shot through all in one go. Okay, there we go. So that's my next slide. And this really shows one of the drivers for the big study that was carried out in the UK. And Richard Dole referred to this as one of the most prominent features of descriptive epidemiology in the early part of the 20th century, of course, together with lung cancer. And it's a pretty dramatic rise of childhood leukemia mortality from 1920 to 1960, a fourfold increase, which still hasn't been fully resolved even today. But this led to Alice Stewart in the University of Oxford initiating a large case control study, a nationwide case control study in the early 1950s to try and see what was going on, what might be behind this rather dramatic rise in childhood leukemia mortality, and this became the Oxford Survey of Childhood Cancers, the OSCC, and the first results were published in the Lancet in 1956. And although they weren't exactly presented like this, this is how we would present it today. From these first 3 years of the study, over on the left, you can see the sort of exposure that occurred during pregnancy, abdominal, other, or none at all. And then for two categories of childhood cancer, leukemia, and other cancers, cases and controls, and the relative risk you get from the cases and controls as compared to the reference no exposures. And you can see going along for the abdominal exposures, both for leukemia and other cancer, the relative risk is significantly raised by a factor of about 2. And that is not the case for other exposures. Slightly raised, but way adrift from being statistically significant. So this was the first sort of indication that there might be something going on from low-level exposure in pregnancy. And in these years 1950 to 1975, then about in the UK, about 10 to 15% of pregnancies underwent some sort of X-raying, mostly in the third trimester and the last month of pregnancy. And the fetus, the dose would have varied, but the dose would have been around about 10 milligray of X-rays. And it is interesting, right at the start, from this sort of frequency of X-raying in pregnancy, that would not, with a relative risk of 2, accounted for that dramatic rise of childhood leukemia. So although this was an interesting finding, it doesn't actually explain that rise in the first half of the 20th century. Now, with all studies of medical exposures, one has to take great care, because although we rely heavily on the Japanese atomic bomb survivors, and the other exposed groups provide useful complementary evidence to the bomb survivor results. You do need to take care in medical exposures, because exposure occurs because of a known or suspected disease. Therapy, of course, for a known disease, and diagnostic exposure when you suspect a disease. And this can have an effect on risk estimates. You have things like confounded by indication, such that a particular disease might lead to a greater frequency of X-ray examinations, but that disease in itself leads to a greater risk of cancer. And so one has to be careful about these often subtle effects going on in the background of medical studies. That these selection effects are a distinct possibility, which must also be borne in mind when looking at these results. And of course, there are problems with doses, and accurate dose estimates with these studies are often lacking. And that includes the in utero studies, as we shall see. Now, these preliminary results were somewhat controversial that Alice Stewart put up into the Lancet, and indeed, many of these concerns were justified. There were doubts about the way the control children were selected in the study, so there's a possible selection bias. The X-ray exposures at this time were obtained from maternal interviews, so there was possible recall bias in terms of a different recall by the mothers of children who had died versus those who were mothers of healthy children. And indeed, it was not believed, particularly at that time, that low doses of X-rays could induce cancers, especially solid cancers. So there is this possibility of confounding by indication, maternal ill health, for example. So all these potential problems were raised at the time. However, in 1958, in the British Medical Journal, Stewart and her colleagues published an updated study, and these initial findings were confirmed. The association with abdominal exposure in pregnancy and childhood cancer was confirmed. So it wasn't just an initial chance effect. And most importantly, I think that Brian McMahon carried out a very impressive study in the Northeast USA, which addressed both control selection bias and case control study, because it was a hospital-based study. It's a case cohort study, which relied entirely on hospital records of exposure. And also the cohort was a subset of all births in these hospitals. So that was a very impressive study, which confirmed the findings of Stewart in the UK. And indeed, later on, the Oxford survey, the maternal reports were largely confirmed, not always, but largely confirmed by medical records when they were looked at. So some at least of these initial concerns over the association were met by other studies and by further examination of records. So the Oxford Survey of Childhood Cancers, which was a case control study of mortality rather than incidence, it went on until 1981 when it terminated, and of course survival by that time had become quite substantial. So studies of mortality were becoming less influential. But you'll see that over 15,000 case control pairs were eventually included in the Oxford survey, which is pretty impressive. Overall, if we look at all childhood cancers combined, deaths from all childhood cancers combined, then there is this very impressive relative risk, highly statistically significant, as you can see, of about a 40% proportional increase in risk by the time the study had completed. And what we have been able to do is to compare the Oxford survey for appropriate combined or all other studies that you can find in the literature. And this is what this table does here for all childhood cancers combined, both for the Oxford survey in the top row and all other case control studies in the bottom row. And there's the various numbers that appear for cases controls and the statistical information. And you will see from the bottom row that the relative risk from all the other cancers is also highly statistically significantly raised. So this is not a result which is confined to just the Oxford survey. It is a general finding. Now, most attention in case control studies has been directed towards childhood leukemia for a number of reasons, including this increase that was observed in the 20th century of childhood leukemia mortality. So when we look at the most recent result from the Oxford survey for when childhood leukemia was examined as a separate entity by Bithell and Stewart back in 1975, you can see that the relative risk is 1.49, again highly statistically significantly raised, so around about a 50% increase, proportional increase in childhood leukemia mortality from the Oxford survey, and quite a number of other studies have now been conducted around the world to check this out for childhood leukemia. And I'm not going to go through this quite clearly, but this is just to illustrate to you just the number of studies that have been conducted which provide information on this subject of childhood leukemia and irradiation in utero, diagnostic irradiation in utero. This actually isn't all of them, but you can see there's quite a quantity. But when you bring them together, and this is for childhood leukemia, again, comparing the Oxford survey on the top row to all other studies appropriately combined in a meta-analysis, although there is a slight reduction in compared to the Oxford survey, as you can see there, 1.28, possibly due to the lower doses of later studies, but nevertheless, that relative risk from all the other studies combined is highly statistically significant. And so there is confirmation from these other studies that of this statistical association for childhood leukemia that was initially reported from the Oxford survey. Well, what about childhood cancers other than leukemia, the other childhood cancers? And you can do the same thing here, which I've done over the past few years with John Bithell, who now sadly died last year. But once again, the Oxford survey at the top and all the other studies appropriately combined in the meta-analysis in the bottom row there. Again, highly statistically significant elevation of risk of all other childhood cancers apart from leukemia. So it's not just childhood leukemia association, it is an association that extends to the other cancers as well. The Oxford survey has been looked at in some detail, and what you're seeing here is the number of X-ray films that were used in an antenatal X-ray examination. And you can see a statistically significant increase in relative risk of childhood cancer from the Oxford survey with the number of films that were exposed during an antenatal X-ray examination. Well, that's somewhat reassuring in terms of the interpretation of the association, but of course, what that actually means in terms of fetal dose is quite another thing. But that's a good start in terms of examining the association in more detail. We clearly need, in order to get a risk per unit dose, estimates of the fetal doses that are administered during an antenatal X-ray examination. And you've only really got any decent dose estimates for the Oxford survey, and indeed the Oxford survey is the only one that is really large enough to provide risk estimates with a decent statistical precision. So that's what has been done, and what you see here is in terms of the year of birth, the estimates of the dose per film during an antenatal X-ray examination. The squares at the bottom are some estimates from Ardran, which are a rather strange set of estimates because he was just rung up by Alice Stewart and asked off the top of his head what he thought the doses were, with no expectations that they were going to be used seriously. So I think even Ardran would say that we shouldn't take too much notice of these bottom estimates. Then along came Unskier in the 1972 report, and you can see in the triangles there dose estimates in terms of dose per film by year of birth, and the line is a fit conducted by Biffle and Stewart. Now, Unskier occasionally goes off the rails, and this was one occasion when it did. And Robin Moll, who didn't suffer fools gladly, made it very clear in these papers here that if you look at the studies that were relied upon by Unskier, you couldn't actually get the doses that they published in the 1972 report. He very strongly suggested that the only decent dose estimate that you get is this little one down in 1958, which was a nationwide survey in the UK by the Adrian Committee, and Moll was pretty insistent, as indeed he could be, that this was the only dose that could be relied on at all, which was not particularly helpful. But what John Biffle did was to fit the relative risk, is what you see here, is the relative risk of antenatal of childhood cancer, all childhood cancers combined, when you look at the year of birth. So these are birth cohorts that you look at here, and there is this significant reduction in relative risk by year of birth, but you have this rather puzzling increase for births in the late 1960s and 1970s, which may very well be artificial, and I suspect it probably is. But what John Biffle did was take the dose estimate from the Adrian Committee that we saw for 1958, and essentially anchored that fit into the dose estimate for 1958 to get this estimate of the proportional increase in risk, the ER per unit fetal dose. So the Adrian Committee came to the conclusion that the average fetal dose per antenatal X-ray examination in 1958 was about 6 milligray, and therefore, if you use that dose with this fit here, so here's 1958. So you sort of anchor it in there, and you come out with this excess relative risk coefficient here. So it's a 50% proportional increase in the risk of childhood cancer at 10 milligray of X-rays. That's what you come out with as an estimate. Obviously highly statistically significant, but that seems to be the best you can do from the Oxford survey, and that's taken to be the same for leukemia and other cancers, because these have got the same relative risk. So one has to be careful in looking at that for a number of reasons. First of all, the confidence intervals there only consider the statistical errors. There are other errors lurking around that have not been taken into account: dosimetry, modeling, and other sources. And this upturn that I referred to earlier, if you recall here, which is very strange, if that is artificial and doesn't really reflect anything. And there are good reasons to think that it might be, that I haven't got time to go into here. But if that is indeed artificial, then that risk coefficient that we've just seen of 50% could be an overestimate by a factor of up to 4. So what other information have we got? Well, a good source of information, as ever, is the atomic bomb survivors, those who radiated during the atomic bombings of Hiroshima and Nagasaki in 1945. And there were some survivors, you can see about, in this particular example, about 800 survivors who received doses of at least 10 milligray during the bombings. These had an average dose of about a quarter of a gray. Not large numbers, but you can see there were 2 incident cases of childhood cancer in these survivors, a liver tumor and a kidney tumor, compared with about half a case expected from contemporary Japanese rates. Rather rough and ready figures, but if you use those with the dose estimates, you come out with a proportional increase per gray of about 11, which is a marginal statistical significance. So you can compare that estimate from the atomic bomb survivors with an average dose of about a quarter of a gray with the Oxford survey dose estimate with a dose of about 10 milligray. Big difference in doses there, of course, and there's the 2 estimates. So statistically compatible, but nevertheless, you can see that one is 4 to 5 times greater than the other, but some support. In particular, what is of interest is that in the bomb survivors who radiated in utero, quite unlike the bomb survivors who were radiated as young children, there was no case of childhood leukemia, which on the face of it is surprising until you see that only 0.2 of a case was expected in the bomb survivors. So it then leads to quite a wide estimate of risk per unit gray. The 2 other childhood cancers lead to an excess relative risk per gray of 22, which is just about statistically significant. As I say, only 2 cases, so you can't make too much of it. But that's compared with about 50 for the Oxford survey. So the other thing that you have to bear in mind is that there could have been cases of childhood cancer, in particular childhood leukemia, that were not registered or were not diagnosed before 1950 when the study started, and there were a lot of infectious illnesses for a start at that time. So it has to be considered. I think one of the most interesting results that comes out of looking at the bomb survivors irradiated in utero is this study of stable chromosome translocations in terms of the intrauterine dose, and the filled in circles are the translocation frequency by the survivors who are radiated in utero, and you can see that these black dots, there was a marginally significant increase at low doses down there, but then nothing to speak of as you go up to moderate and high doses, which is most strange because the line there is the sort of dose response one might expect, and the scientists carrying out this study were so surprised about this that they actually got blood samples from the mothers of some of these in utero exposed. You can see that these are the open squares, and the mother's translocation frequencies followed what one might expect. So we're left with this very strange result, which really does need to be explained as to why the frequency of translocations in the survivors who are irradiated in utero does not show the expected variation with dose. It could very well be due to the nature of the fetal hematopoietic system, but a very interesting result in my mind.
Richard, sorry, we are out of time. If you can.
Yep, I'm just drawing it to an end. And
yes,
so,
thank you.
I should say that there is increasing evidence, and the paper has just come out from Sugiyama et al. Of evidence of excess deaths in those irradiated in utero in adult life, but strangely enough, only in females rather than males. So that's something that's got to be sorted out as well. And finally, you remember that this comparison of the Oxford survey and the other studies combined, which sort of showed both childhood leukemia and other childhood cancers, that you have this compatible increase in relative risk. And John Biffle and I have looked at this over the years to see how this might break down into the individual childhood cancer types between the Oxford survey and the other cancers. And this will be published in the near future. But so interesting patterns there, but generally confirmation from these other studies of what you see in the Oxford survey. So there's my conclusions. Interesting stuff. There's questions that need to be addressed to provide confidence in the validity, but it looks on balance that the association could very well have a cause and effect association. So low levels of radiation exposure in utero lead to an increased risk of childhood cancer. And there we go. That's the end. Thank you.
Thank you very much, Richard, for your presentation. I would like to remind the audience that they can put their question in the Q&A panel that you see on the right part of your screen. We have seen already there are some questions, and the questions will be answered during the discussion session at the end of this first part, so at 15:45 according to the schedule. So now it is my pleasure to introduce the next speaker. He is Professor Kimberly Applegate. She is a retired professor of radiology and pediatrics at the University of Kentucky School of Medicine, and she is a member of the main commission of ICRP, and she's chairing Committee 3 Radiation Protection in Medicine. And Kimberly will speak about biological and genetic effects. So please, Kimberly, the floor is yours.
Thank you very much for this invitation and the introduction. And I'm so happy to be here. Let me make sure I can move these slides. First, I want to disclose that I am neither a radiation biologist or a geneticist. However, I am a pediatric radiologist, and by far the most common anxiety-provoking imaging testing that I have done over decades has been involving ionizing radiation to the fetus or to the baby. And so this issue comes up a lot, and the babies are often very premature, sometimes as early as 23 weeks, so that this issue is near and dear to my heart. So let's talk about this a little bit. For everyone to understand where some of these publications come from that I've tried to synthesize for our discussion today, many of these are from the ICRP and the NCRP. Some of them go back a bit and are undergoing some updating, but publications are from 84, 90, 95, and include all kinds of information from animal studies and human studies, which are, of course, more limited in mortality, human teratogenesis, and cancer, and some later adult diseases, which we continue to look at as Richard has just discussed. And then NCRP Report 174, and of course, many of the RERF studies from Japan, which are ongoing and continue to provide us from very interesting information, and then a few more from Chernobyl. The cancer risk that I want to use in quotation is that fetal risk equals early childhood risk that we have used for a long time. I just question it because of my work with premature infants and wonder if there's an opportunity to look at that some more. So I bring this up to the general group here to say, I wonder if we could look at that a little more carefully. So I thank Richard for covering that topic. And I'm going to expand a little bit on that by talking about pediatric predisposition syndromes, and then talk a little bit about frequencies and doses of medical imaging exposures of pregnant women and some recent CT publications, and then talk a little bit about gaps and some questions. So let's do a brief biologic evidence review, which thankfully Richard has covered a bit, but start with what is any risk that we know about preconception ionizing radiation. There is no known human germline mutation risk from radiation from the 2-week period before conception or for years before. But some question, are we unable to detect it? So there's this kind of open question mark, but by and large, no known risk. We know there are somatic cell mutations that occur in both humans and animals, but through multiple cohort studies, there are no increased heritable genetic mutations. And these studies include offspring of the Japan atomic bomb survivors, childhood cancer survivors, radiation workers, looking at any excess of cytogenetic syndromes, single gene disorders, malformations, stillbirths, neonatal deaths, and so on. Now let's move on and talk a bit about non-cancer embryo and fetal radiation effects. It's really important that we understand that the baseline congenital malformation risks are already significant. So we have to detect some of these things on top of a 15% spontaneous pregnancy loss, which typically occurs early, sometimes before the woman knows she's even pregnant. And then there is a 3% risk of major malformations and 4% of minor malformations, and 0.4% of mental retardation, which is defined as an IQ of less than 70, and 4% of microcephaly. Now, teratogenesis involves a number of, a list of these different items, which I'm listing here, mainly looking at the central nervous system, because these are the things that the Japanese A-bomb survivors were studied, and we're going to talk about a little bit more, but also involve any of the major organs. So we're going to go into that in a moment. And then we look at genetic risks, where there were no definitive risks in humans from ionizing radiation, but they're estimated to be very small and higher in the female fetus than the male. And I want to mention that these were first reported by Mueller in fruit flies in 1927, which in medicine, this is important because it led to our guidance statements decades ago to use gonadal shields in medicine, which has currently been undergoing some changes in policies in a number of different organizations. So I think this slide is very helpful in giving a summary of timing and how important it is to when the ionizing radiation is exposing the embryo or the fetus. Days post-conception is so important to when that human fetus is being exposed and what potential effect we might expect, and we might advise or counsel the mother and the family. There's the all or none phenomenon that we talk about before implantation, and there's only one effect that we think about, and that's prenatal death. We need a high dose for that. Then there is the, once there's implantation and early organogenesis, that is the key, very sensitive period where we look for neuropathy or neuropathology, growth retardation, and the malformations. Later, after major organogenesis has occurred, all of these concerns fall off with fetal growth. And if you see in this graph, Note that the carcinogenic risk is small, which Richard talked about, but it's the same, or it's purportedly the same throughout the fetal life. Note that there is a linear increased frequency of mental retardation with dose at about 40% per gray without a threshold, although there is also some question about whether there is a threshold. Let's give just a couple of more details about thresholds for these non-cancer ionizing radiation effects. The pre-implantation threshold is at 150 milligray, we think, for pregnancy loss. And for the major organogenesis phase at 2 to 8 weeks post-conception for critical malformations, it's a higher dose at 250 milligrays. That's an estimate. And at 8 to 15 weeks post-conception, we worry about neuropathy and growth retardation with doses at about 100 milligray or higher. Later on, at 15 to 27 weeks post-conception, we worry more about neuropathy and growth retardation at higher doses. After that, at 27 weeks and beyond, we know from Otake and Scholl that there is no evidence of radiation effect on intelligence among children, just like we haven't seen that prior to 8 weeks. So in animal studies support this conclusion, and the biologic mechanism is proposed that there is resiliency and repairability of the CNS. So to get some idea about these risks in calculating it down to the medical imaging level, at the 10 milligray level that, for example, Richard was talking about, which in the 1950s would be an abdominal X-ray, but today would be an abdominal pelvic CT. And in the peak risk period of early organogenesis, the risk of microcephaly at 4 to 7 weeks would be about 5 women per 1,000 women undergoing CT on a background rate of 40 per 1,000 women. A little bit later, microcephaly at 8 to 11 weeks would double, and mental retardation at the 10 milligray level would be below threshold. And I mentioned that it's just not detectable, but maybe some effects of IQ effects might occur, but we may not be able to detect it. And that's what I'm talking about, and that's what I worry about. We may not be able to detect it. And I just want to note that you can have microcephaly with or without mental retardation and vice versa, so it makes it difficult for us to say anything about any ionizing radiation effects if we detect microcephaly, say, for example, on an ultrasound during pregnancy after ionizing radiation exposure. So actually, Richard mentioned some of these CNS effects from the Japanese in utero cohort, that there was a decrease in IQ of 25 points per gray at that most radiosensitive period. There were other effects that have been documented both in this cohort and also in animal studies. And I'm not going to be able to go through the many animal studies in rodents and other animals to support this finding. But I want to mention some caveats, and one is from NCRP 174, and some difficulties that don't always align with this major guidance, that there are not enough data available to inform on which stages of pregnancy may be the most vulnerable for oncogenic effects of radiation. And then Richard also mentioned the Sugiyama paper that just came out, that there are continued risk of tumors in females, but not in males. And for the non-cancer effects, which I found very interesting, they have followed this cohort of in utero exposures of the Japanese A-bomb survivors that show complex factors interact in non-cancer disease mortality, looking at birth weight, small head size, and parental loss. So this will be interesting to follow the findings there. Moving on, I want to talk about the importance of what we know about ionizing radiation sensitivity in these syndromes that we know and have known for some time, and then talk about some others that we haven't known so much about. We know that we need to avoid radiation exposures in medical imaging when possible, and disclose when we're not sure. Ataxia telangiectasia is one of the most well-known syndromes that we want to avoid radiation. And then there are a number of others, and a growing number. I'm not going to read these all, but there's an open source registry called OMIM. This is one of the newer ones that has been added. And I'll also mention trisomy 21 or Down syndrome is one that some of us would like to make note of to try to avoid ionizing radiation where possible, yet they do get a fair amount of imaging. They're at risk for cancers like lymphoma and leukemia, and BRCA1, BRCA2 carriers. There's an association of chest x-rays in children having leading or association with breast cancer later on. So these are some more subtle associations. Just a mention of the population impact of ataxia telangiectasia. It may be rare, but there are many carriers. And so even as a carrier, there's a known increase of breast cancer. So what do? They don't know that they have this, and it would be, I think, interesting to be able to screen for these someday. Let's move on to the pediatric cancer predisposition syndromes and how, what kind of insights we might learn from this group. There was a pediatric cancer working group formed in the American Association for Cancer Research. In 2016, they put together guidelines, and this is now an international consortium. They made recommendations for surveillance of children they looked at 50 of the more common known cancer predisposition syndromes, and they outlined their recommendations and guidance in 17 open source articles in the Clinical Cancer Research Journal. This was spearheaded by Garrett Broder, and they defined the risk of cancer in children by that risk of at least 5% by age 20, and the cancers had to have some form of effective surveillance and management. And the current estimate is that pediatric cancer associated with a germline mutation is at least 10%. So the justification for this guidance was it wanted to have a tribute call out basically to Dr. Alfred Knudsen, who described modern cancer genetics and hereditary predisposition. He described a two-hit theory of retinoblastoma, and I highlight blastoma for a reason, in 1971, which is still relevant today, which is a dominant inheritance form of one mutational event via germ cell and via somatic cell, or the non-hereditary form of two mutational events in the somatic cells. He then extended his research to neuroblastoma and to Wilm tumor, which is also called a nephroblastoma, in 1972, and on to other adult tumors. And I bring this up because these blastoma tumors, which we see in children not uncommonly, are basically tumors that have fetal tissue, blastomas, that don't turn themselves off and turn into bad acting tumors. And I'll mention that the ICRP publication 79 of genetic susceptibility to cancer made recommendations at the end of their report some years ago that said, please consider not just the radiation sensitivity due to tumor suppression gene deficiencies, which in a way these tumors are, but also reduction in tumor latency. So some of these children, these predisposition syndromes, have not only one cancer, but they get 2 or 3 cancers in childhood. And an example of that is Dicer syndrome. So one of the key takeaways from this consortium is that the guidelines recommend avoidance of ionizing imaging in favor of non-ionizing radiation use. And I think that's not well known in the medical community. And so I hope that one takeaway from this talk is that you all will go home and tell your medical colleagues about this. An example, probably a most well-known example of the CPS is Framini Syndrome, which is a variable expression associated with a germline mutation in the TP53 tumor suppression gene. And they recommend that whole body screening with MR, and when we mean whole body, we mean cranial vertex to toes in Framini. Some of the other whole body MR protocols are not whole body, they're modified to just include the trunk. It just depends on the syndrome. And then also, if liver lesions are detected, they'll screen, for example, with contrast-enhanced MR, or sometimes or ultrasound, or sometimes MR. I have to show you one MRI, which is usually for whole body coronal imaging with some axial or sagittal. And this is from Greer from Toronto Sick Kids, her protocol of 2 children. And this is in a Framini children, where we look at children tumors differently than adult tumors. And I want to bring that out so that we understand where to look in different age groups, and also different phenotypes, because the families will manifest different phenotypes, and we'll definitely want to know their histories. So we can do this screening often without using gadolinium, which has its own harm that we try to avoid with diffusion weighted, which is on the right hand image. So these tumors, again, have blastomas that we're looking for in childhood and not so much in adulthood. So this, the whole body MR surveillance recommendations include a number of tumor predisposition syndromes in childhood, including neurofibromatosis. And for type 2, we add things like brain and spine MR. And for others syndromes, we recommend not whole body MR, but focal imaging, such as abdominal ultrasound for Beckwith-Wiedemann or hemihypertrophy. And for von Hippel-Lindau, it would be brain and spine. Now, may I say that we need to move on and talk about the appetite for imaging, which is almost as much as our American appetite for the hamburger. And we need to understand that we have decreased our dose per exam through a multiple stakeholder collaboration and improved technology and optimized protocols. But what we have also done is increased our exam applications like CT angiography, and in the pregnant women, CT pulmonary arteriography has often replaced nuclear medicine. And the tumor imaging, trauma imaging and interventions have significantly added to fetal dose. What we have also lagged is justification sometimes for the amount of imaging, and I'm going to show you examples here. How much dose does diagnostic imaging procedures expose in the embryo fetus? Today, if we do either accidentally or purposely image the pregnant woman, it's going to be less than or equal to 10 milligray. And with interventions to save a woman's life, it would be less than 50 milligrays on average. But we want to consider cumulative CT doses, which Madan Rahani and his colleagues have started publishing from 2019 to just this past month. And I just want to quote this from one of their papers, that CT in 344 hospitals in 20 countries showed 0.64% to 3.4% of the patients undergoing CT examinations reach cumulative effective doses of greater than 100 millisieverts in a 1 to 5 year period. The papers estimated that about 0.9 million patients probably reached this greater than 100 millisievert dose every year globally through recurrent CTs alone, and nearly 20% were age less than 50. And I mention this because those would be fertile women. Okay, how frequently do pregnant women get imaged in the abdomen pelvis? Most often it's in the first trimester before they're aware of pregnancy, and up to 1% of all pregnant women were estimated to get this in a paper by Mossman in 1982. That's a long time ago. Let's look at more recently. 11% of trauma patients were unaware of pregnancy in one institution that Bill Mayo Smith looked at Brown in Rhode Island. That was in 2009. This is an IVP image of a third trimester pregnant woman with an obstructing stone on an IVP, where you can see the dye through an obstructed urogram and the baby's head. You can see the skull and then the spine. And then we have data that shows an upward trend in CT use both in America and Canada. Bill Mayo Smith's paper looked at a decade of abdominal CT use and showed it had doubled in that time period. And the most common non-trauma diagnosis was appendicitis and ureteral stone. The CTDI vol dose average was 4.3 milligray, and it ranged up to 44 milligray. And then a much larger cohort that was published in JAMA Network Open in 2019 by Kwan and colleagues showed that 0.8% of women in America and 0.4% of women in Canada underwent CT. And even more interesting, 5.3% in the US and 3.6% in Canada underwent some form of ionizing radiation. And that's just something to look at over the 20-year period of 1996 to 2016. So there may have been a dip during the global recession, but it still continues to go up. Okay. So I want to thank you for your attention, and hopefully it's provoked some discussion.
Thank you very much, Kimberly, for very interesting information and presentation. And you show also in this slide this important message, one size fits all. That's a slogan, if I remember correctly, of the Image Gently campaign, of which you are an active participant. Now I move to the next presenter. The next presenter is Sigri Leider Schweckborn from Sweden. Sigrid is Associate Professor of Medical Physics at Lund University, Malmö Hospital. She is member of Task Group 36 of ICRP, radiation dose to patients with radiopharmaceuticals. And she has made several training and advisory activities for IAEA, EANM, and other society. And she will give us an information introduction about assessment of doses after incorporation of radionuclides. Please, Sigrid.
Thank you very much. And thank you very much, Professor Gisani and Professor Pajic, and the organizer of this winter school. It's a very interesting topic you have chosen, and it's very important. The title of my presentation is Assessment of Doses to Embryo and Fetus After Incorporation of Radionuclides. I'm going to concentrate on the application where I have my experience, and that is in administration of radiopharmaceuticals to pregnant patients in nuclear medicine and the assessment of the fetal dose for those. Most of what I'm going to say is, however, applicable also to irradiation of an embryo or fetus from radionuclides within a pregnant woman from occupational or environmental sources, because it's about internal dosimetry. 1,000 of pregnant women are exposed to ionizing radiation each year worldwide, as we heard Kimberly talk about. And lack of knowledge has probably led to abortion unnecessarily. For most patients, radiation exposure is medically appropriate, and the radiation risk to the embryos and fetus is minimal, even though there might be some risks, and I will go through those later. Because there are, however, exceptions. There are occasions when the fetal exposure will result in significant harm to the embryo and fetus, and where you may have to advise abortion, and I will talk about that later. In the medical specialty nuclear medicine, both diagnostic and therapeutic, radioactive substances are administered to the patient in order to demonstrate or exclude pathologies or diseases, or for therapy, and also for follow-up of treatments after therapy. And these radiopharmaceuticals, they can be administered in different ways, but most often they are administered as intravenous injection, intradermally, orally, or via inhalation. And thus the activity is distributed within the mother, and it will irradiate the embryo or fetus externally. A majority of the radiopharmaceuticals used in nuclear medicine is excreted through the kidney bladder system, as you can see in my example here, where you can see activity in the urinary bladder of a patient that has undergone bone scintigraphy. And the activity in the urinary bladder of the mother will be a radiation source irradiating the fetus. And as you can see, the fetus is quite close to the urinary bladder also. Then we have some radiopharmaceuticals, they may cross the placenta and actually concentrate within the fetal tissue. And then the fetus will be internally exposure. And I have this one, you can see this is an example where we have pertechnetate in the fetus, in the whole of the fetus, after a nuclear medicine investigation. The magnitude of the absorbed dose to an embryo or a fetus due to radiopharmaceuticals administered to the mother depends on what procedure is carried out, and actually what radiopharmaceutical is administered to the mother or to the patient then. And as you can see in this slide, I show you 5 different examples of nuclear medicine procedures out of approximately 40 or 50 available at a larger hospital. And these demonstrate different whole body distribution of the activity in the patient. In the first one, the patient has got an intravenous injection of technetium-99M labeled diphosphonate for a bone scintigraphy, and the radiopharmaceutical is clearly visible in the bones, and you can see also some in the urinary bladder. In the second one, you see a whole body scan after an intravenous injection of indium-111 octreotide for a neuroendocrine tumor examination, with high activity content in the liver and in the spleen, and you can also see some in the urinary bladder. The third one is also a tumor imaging radiopharmaceutical. It's fluorine-18 FDG, which is a tumor-seeking agent, and you can see it in the tumors, but you can also see it in the heart and in the brain. But in my slide here, you cannot see it in the brain though, because the brain is not part of it. The fourth example is actually a myocardial perfusion scan after an intravenous injection of technetium-99M labeled MIBI. And this substance is used for to see the heart and the heart muscle. And diagnostically, this is the only interesting part of the body. But for internal dosimetry, and especially for determination of the fetal dose, knowledge of the whole body distribution of the radionuclide is crucial. And this is also the case for the last example. That is a brain scan after an administration of iodine-123 labeled receptor substance called ioflupane. And you can see that we want to see the uptake in the brain. But when I have the whole body distribution, I can see that we have huge uptake also in the liver, which is close to the fetus if it's a pregnant patient. So, I have to go back. So what we need to know in order to calculate the fetal dose, it is the distribution and the retention of the radionuclide, the activity in the organs. We need to know also the excretion routes, and for a majority, as I said earlier, the urinary bladder is the organ that contains a lot of activity. But as you see in my fourth example here, we also have activity in the intestine, and the intestine is also close to a fetus or an embryo. Then we need to know what radionuclide it is. We need to know the physical half-lives of it and the type of radiation and energy emitted from the radioactive decay. And finally, it's very important also to know if the radionuclide crosses the placenta and concentrates within the embryo or fetus, and in that case, to what extent. So why do we have to know the dose to the embryo or the fetus? Well, the radiation risk throughout the pregnancy is related to the absorbed dose to the embryo and fetus. And the risk is also related to the stage of pregnancy at the time of irradiation. The radiation risk is most significant during the organogenesis and in the early fetal period, and somewhat less in the second trimester and least in the third trimester, as this shows in ICRP publication 84. And now we have heard both Professor Kimberly and Professor Wakeford telling us all about the risks and the effects. And this information is from ICRP 84, telling us about the early effects and the effects on embryo and fetus during growth. And there are threshold doses, and Kimberly told us about that there maybe is not a threshold for mental retardation, but for the others, there may be a threshold of 100 milligray or more than that. But on top of that, there is a risk for cancer, for leukemia and solid tumors, as they have both told us about. And what I want you to know is that according to that excellent paper, ICRP 84, we can get more information also. And so how do we calculate, how do we determine the fetal dose? Well, there is one easy way to do it, but that is not so thorough, and that is to estimate the dose to the uterus of the mother. And the uterus may be used as a substitute, at least for the first 2 or 3 months before the embryo has grown too big. But this approximation presumes no placental crossover. If you, however, want to know the dose to an embryo or fetus in the first, second, or third trimester, when the fetus is bigger, there are a couple of publications to turn to, and I will go through them in more detail. The uterus may be used as a substitute at least for the first 2 or 3 months before the embryo has grown too big and with no placental crossover. Sorry, I think I have. So, and the doses to uterus from some 100 different radiopharmaceuticals used in diagnostic nuclear medicine can be found in the ICRP publication 106 or 128. The title is Radiation Dose to Patients from Radiopharmaceutical. It is, however, very important to emphasize that these biokinetic models are based on a population and cannot be used for individual dosimetry. The ICRP 128 is currently being updated with more radiopharmaceuticals recently developed and with revised biokinetic models for some of the older but yet popular substances. And you see in this table at the bottom the dose to the uterus. But these are the uterus to the mother. And if you need to know the fetal doses, the actually fetal doses, you can go to the ICRP publication 84, for instance, where you can find a chapter on nuclear medicine. And there is a table that you can find the fetal whole body dose for some common nuclear medicine examinations in early pregnancy and at a 3rd trimester. And part of this table can also be found in a PowerPoint slide available as an educational material at the ICRP webpage. And both these are actually presenting the same information, and they are to some extent adapted from a paper by Russell, Stabian, Sparks, and Watson that was published in Health Physics 1997. So, how do we calculate this? How is the absorbed dose to the fetus determined? Well, it is by internal dosimetry. If you're using the MERD scheme, the MERD schedule, you can use this quite simple equation, but behind it, it's more complex. You define a target organ and a source organ. And in this case, the target tissue is the fetus, and the source tissues are the activity in the organs of the mother. So the target is the fetus, and the source may be the lungs of the mother, or the urinary bladder, or the intestines of the mother, where we have the activity. And actually, I have used the ICRP nomenclature here, but it is the same as the standardization of the nomenclature. I just think that this is for simplification. So the mean dose to a target tissue, in this case the fetus, is determined by a simple multiplication between the cumulated activity and the S value. And the cumulated activity, that is the total number of disintegrations, is the activity in the source organ over time, and that is in the mother, the megabecquerel hour. So that is why we need to know the activity distribution and the retention of the activity in all the organs and tissues of the mother. The S value is a factor that gives absorbed dose to a target region from activity uniformly distributed in each source region. And this S value includes a lot. It includes the mean energy emitted per nuclear transition. The S value does also include the fraction of energy emitted in source region that is absorbed in a target region. And it also includes the mass of the target region. The two latter parameters is included in a quantity called specific absorbed fraction. And the specific absorbed fractions for various types of radiation of different energies are determined by describing reference phantoms. In the paper of Russell et al. From 1997 that I have here on my slide, The SAF values are based on mathematical phantoms describing a pregnant female in early pregnancy, and that is actually the uterus, and the first, second, and third trimester. The fetal doses published in that paper of Russell et al. You can see table 3 here, and it is the absorbed dose estimates to the embryo fetus per unit activity of radiopharmaceutical administered to the mother. And these are dose coefficients, so the unit is in milligray per megabecquerel. And if you look, we take the next one. And if you look at the next table, 4A, is the fetal dose estimates. They have actually taken the dose coefficients and multiplied it with reference activity administered to the mothers. And these reference activities is what the ordinary nuclear medicine patient will get. So these two tables show the fetal dose from external irradiation from the source organs of the mother. And they are published in this publication by Russell et al. But as I said earlier, some radiopharmaceuticals, we can see that the activity have been shown to cross the placenta, and not only maternal contribution, but also the fetal self-dose has to be taken into consideration. And the first example here is technetium-99M in the whole body of the fetus, and that is pertechnetate that has escaped, or what is a free pertechnetate from MDP that has been given to the mother that dephosphonates. The second example I have here in this slide is sodium iodide with iodine 131 given to the mother for cancer therapy. And you can see parts of this ending up in the amniotic fluid and also in the thyroid of the fetus. So in the second paper of Russell et al. From 1997, the placental transfer of different radiopharmaceutical has been investigated. And in table 3B, in the first paper by Russell et al., both the maternal and the fetal self-dose contribution, when applicable, have been included in the determination of the dose coefficients. So for some of the radiopharmaceuticals, we do have enough information to have a complete dose estimate for the fetal. However, those two publications I just mentioned from Russell et al., they are almost 25 years old now, and more knowledge has been gained since then, and especially intense development of more accurate anthropomorphic phantoms for a pregnant female has led to revised specific absorbed fractions. And this has resulted in a computational phantoms for the pregnant female by Mike Stabin, and corresponding fetal dose coefficients for a great number of radiopharmaceuticals for early pregnancy and for first, second, and third trimester. And this has been published in the Journal of Nuclear Medicine 3 years ago, and they do also include the doses for some new substances. And this table includes both maternal and self-dose when appropriate, and those substances that also have the fetal self-dose, they are shared in the shaded rows, as you can see in this image, this slide. So, using the values on fetal dose coefficients presented in this table and reference activities for the diagnostic nuclear medicine procedures, the whole body fetal dose would be around 1 to 10 milligray for a procedure with radiopharmaceuticals labeled with technetium-99M, and approximately 10 milligray for a fluorine-18 FDG examination. And the high dose examination, as I call it with brackets, indium 111 pentotriotide will result in a fetal dose of approximately 20 milligray for 185 megabecquerel administered to the mother. And comparing these values with a threshold dose for deterministic effects of an embryo fetus, one can summarize that probably prenatal doses from most properly performed diagnostic procedure using radionuclides with short physical half-lives present no measurably increased risk of prenatal death, malformations, or mental impairment. But nevertheless, there are the risk of cancer, and there are no threshold doses assumed, and the risk may be also for lower doses. But you should not be completely alarmed. There are, however, exceptions. As I began in my presentation, there are occasions when the fetal exposure will result in significant harm to the embryo and fetus, and I will give you an example of that now. Administration of radioiodine to a pregnant patient will result in the concentration of iodide also in the fetal thyroid, since the iodide crosses the placenta. And this fetal thyroid concentration starts already 8 to 10 weeks post-conception. So if we're using the table of Stabin, the whole body fetal dose will be not so high, approximately 0.1 milligray for an uptake measurement with iodine 131 of 0.4 megabecquerel. Or if we are using it for therapy and we're giving the mother 500 megabecquerel of iodine 131 sodium iodide, the mean dose to the fetus will be approximately 145 milligray. And that is not so alarming, but this is without the placental crossover. Because we have the placental crossover and the concentration of iodide in the fetal thyroid, this will result in high fetal thyroid doses, which can end up in permanent hypothyroidism and with the risk of severe physical and mental retardation due to deficiency of thyroid hormones. So this could be really alarming. And I have a horrid example here. This is an example from Gothenburg in Sweden. It was a pregnant patient that was referred to a radionuclide therapy with sodium iodide 131 for cancer treatment. And she got 3.7 gigabecquerel, that is 3,700 megabecquerel of iodine 131. And 6 days later, one could see uptake of iodide in the thyroid bed, in mammary glands, and in the fetal thyroid and the fetal amniotic fluid. And the fetal thyroid dose was calculated to be more than 300 gray, not milligray, but gray. And in this case, the fetus did not survive. And we have another example also in the same, with the fetus that did survive but got really harmed. So despite investigation of possible pregnancy, it still happens that pregnant women are treated either because of incorrect information or because the pregnancy is such an early or late stage that a conventional pregnancy test with urine test is not positive yet, or is not positive at least. So instead, a blood sample should be analyzed in addition to an abdominal or vaginal ultrasound examination. And there are also other radionuclides used for therapy, and the purpose of that is, of course, to get a therapeutic effect, and the physical half-lives for these radionuclides are quite often quite long. So for all radionuclide therapies, you should be very cautious. And with this, I will have a conclusion of what I've said. And in nuclear medicine, sometimes we get patients, and we are very cautious for everyone, or even though they are diagnostic procedures. But most diagnostic procedures are done with short-lived radionuclides, such as technetium-99m or fluorine-18, and they do not cause large fetal doses. So prenatal doses from most properly performed diagnostic procedures present no measurably increased risk when it comes to prenatal death or malformations or mental impairment. However, there is the risk of cancer, so we should encourage the mother to drink more than usual and to frequent urine voiding, because this will reduce the fetal dose markedly and the risk of childhood cancer. And some radionuclides do cross the placenta and can pose fetal risks. And if we are giving the patient radioiodine, as we shall not, but they may cause significant fetal thyroid harm. So if we find out that afterwards, you could give the mother stable iodine, sodium iodide tablets, if pregnancy is discovered early after the administration, in order to decrease the risk. And with that, I thank you very much for your attention.
Thank you very much, Professor Sigrid. With this very interesting and very important lecture we have just heard, we finished the first session of our winter school. I would like to thank Professor Sigrid and the other two presenters for very interesting presentations. As you know, we now have 15 minutes for the discussion, and we invited you to type your questions in this Q&A chat box. So during other presentations, we have collected questions, and also we have collected answers for these questions. You can read them, but I will also read for you a few most important or most interesting questions and answers. So one of them is, what was the dose range which were taken into account as a fetus exposure? Professor Wakeford answered, in earlier years, fetal doses may have approached 50 milligray, but perhaps typically 10 milligray. Later doses will be just a few milligray. Next question, if we have a fractionated exposure, for example, during radiotherapy, what could be correction factor for RR, ERR, comparing this kind of exposures? So Professor Richard answered, the answer is not straightforward, but if the individual doses are low, for example, less than 100 milligray, then the assumption is that the risks will be additive. Higher doses may be less effective for some cancers, for example, leukemia, but this is not established. We also have a question, what would you say are main research priorities in this area for all speakers? And Professor Richard said, as ever, better understanding of radiobiology. Also, the various childhood cancers needed to be better understood. And he's very interested in translocational results for the bomb survivors irradiated in utero. I will ask maybe Kimberly and Sigrid to answer this question also.
Could you repeat the question?
Okay, so the question is, what would you say are the main research priorities in this area?
I think there are a number, and some of them I brought up. One is the question about the threshold for the mental retardation, that I'm interested in that. The other is the oncogenic, the oncogenic risk throughout the stages of the fetus, and we've said that they're the same. So that's a question I have. The third is the statement conclusion of the NCRP 174 that I wonder about the biologic plausibility that it's the risk to the fetus of ionizing radiation is less than the risk of early childhood, which is goes against prior, reports where we've just said that it's the same. So I think there's opportunity to look at as I said, at that question, and by looking at maybe premature children, and there's a very large cohort of premature children in the National Institute of Health NICHD records, which link ionizing exposure imaging, actually all imaging and all medical data of close to 30,000 premature babies. I just haven't been able to look at that, but it is there. They hold it closely, so that's something to think about.
Thank you very much, Sigrid. I would like now to invite Professor Kimberly to answer this question about main research priorities in this area.
Oh, that was, I am Kimberly.
Oh, I'm sorry. Sigrid? Can we hear your answer about main research priorities? Unfortunately, no, but I can maybe...
Can you hear me?
Read the other questions and answers. So one of them was, has digital phantom of pregnant women been developed? And Professor Kimberly answered, great question. Oh, I'm sorry. Well, the answer is great question. ICRP, oh no, yes. ICRP is updating P128, and once that is completed, we will be working on fetal phantoms. Thank you. Thank you for a very interesting talk, Professor Applegate. How, in your opinion, should we improve our clinical practice due to increased safety of mother and fetus? Well, it's hard to answer general with specific, but using the BSS, Bonn call for action is general, specifically ensuring that each facility and worker commits to a culture of safety, teamwork, and learning from safety events and near-miss events. Could mesh phantoms be implemented in treatment planning systems to calculate dose to a fetus when mother undergoes radiotherapy, or perhaps there are other phantoms suitable for that? Do we have an answer here? Professor Kimberly?
I think Augusto would be the best person to perhaps to answer that.
Okay, Augusto, can you answer, please?
Sorry, can you repeat the question?
Yes. Could mesh phantoms be implemented in treatment planning systems to calculate dose to a fetus when mother undergoes radiotherapy, or perhaps there are other phantoms suitable for that?
Theoretically, yes. When the mesh phantoms will be developed, then it will be possible to implement them also in the treatment planning systems.
Okay, thank you very much. So now, since we don't have any unanswered questions, maybe we should continue with the other activities.
Okay. Yes. So I think now in the program we have a break.
Yes.
During the break, you will see some commercials from the sponsors of the meeting. And so we invite you to look at these commercials, but you are also, of course, free to have some free time, have something to grab something to drink and to eat. And we welcome you back in 30 minutes for the second part of this winter school, of this first day of the winter school. So welcome back to the second part of today's session of the EURADOS Winter School. We have had some question in the chat about the availability of the presentations. You will get some information in the next days about how and where the presentation will be available. And you will receive also this information through the EURADOS newsletter. So if you are not yet, if you don't yet receive the EURADOS newsletter, you can. It is a good opportunity to start now to join the newsletter, and you can do it on the EURADOS website. So we can start the second part, and at the end of the first part, we heard Sigrid telling us how you assess those in case of incorporation of radionuclides. Now we have a presentation about Natalia Saltibayeva about assessment of doses for in case of external dosimetry. Natalia has a master in applied nuclear physics from the St. Petersburg University, and she in a PhD university in Erlangen. Now she works as a medical physicist at the University Hospital in Zurich, in Switzerland. And her scientific work is mainly focused on advanced method of radiation dose optimization and patient-specific dose assessment. So Natalia, here the floor is yours.
Thank you very much for the introduction, Augusto. I hope that you can hear me well and see me probably well. Can you hear me? Just yes, no? I just don't know. Okay, all fine. So now I see the feedback. Thank you. So let me then start. As it was mentioned, I'm a medical physicist. I'm working in Zurich currently, and I'm happy to present today this talk called Assessment of Dose to Embryo on Fetus, External Dosimetry. And I'm presenting this talk on behalf of the EURADOS Working Group number 12. So let's start directly. So first of all, since I'm the first one presenting in this session, I would like to quickly remind you, although you had this session just half an hour ago, that the radiation exposure during the pregnancy can be definitely dangerous. And in general, we consider two big group of effects, deterministic effects or stochastic effects. And speaking about the this ionizing radiation effects on the conceptus, on the fetus, we can say that in case of deterministic effects, we normally do care about miscarriage, mental retardation, and different organs malformation. While in case of stochastic effects, we normally mentioned cancer probability and leukemia and different hereditary effects. It is also interesting to mention that in case of unborn conceptus, these two effects might depend on different things, on dose itself, so how strongly the fetus was exposed, and also on the gestation age. For example, the malformation, as you heard, they are mostly pronounced during the so-called organogenesis stage between week 10 and 16. But overall, just to give you a short introduction, that exposure might be dangerous and we should take care and do our best to protect the patient. It is important for both future mom-to-be and also for caregivers. And this is especially nowadays important because the amount of such examinations, amount of radiological examinations performed during the pregnancy are constantly growing. So this is a report from 2006, 2007, but the situation, believe me, is more or less the same. So there is a constant growth in different type of radiological examinations in pregnant patients. For example, this report said that during the last decade, the number of examinations performed in pregnant women increased by almost 100%. This is especially pronounced in case of CT imaging, but in general should be taken into account. Of course, if we are talking about imaging during the pregnancy, the first principle which we should take in mind, which we should consider, is justification principle. So whenever it's possible to use some alternative non-ionizing imaging modalities, we should go for that. So if we can perform ultrasound or MRI, of course, we should consider these options first. But of course, there are some cases when it's not possible. For example, there are just a few examples mentioned here, but of course there are much more, like trauma or kidney stones, when we are not able to see the stone on the ultrasound. And also I found 2 examples from our hospital when the CT examination of the pregnant women was performed. The first case is on the left side. It's a severe trauma patient after the car accident at her 30th week of pregnancy. And on the right side, you can see another woman which was hospitalized after the horse accident, and she was unconscious. So we even were not aware that she's pregnant. So we realized it only after the pregnancy, after the CT examination was performed. So these cases are also not rare, that we first might perform the examination and only after that reveal that the patient was pregnant. And in all of such cases, the dose should be assessed. So we need to know which dose conceptus received from this examination. And in general, today I will talk about the 3 different approaches which can be used in order to evaluate conceptus dose. We can either use normalized standard dose metrics, we can use measurements, of course, and we can use Monte Carlo simulations. So first of all, I will talk about the normalized dose values, a bit shorter, and I explain you why. So if we're talking about the standard dose metrics, of course, this depends a lot on the modality. For example, for radiography, we can either use entrance skin dose or air kerma. For fluoroscopy, we normally can use the same entrance skin dose or dose area product. And for computer tomography, we normally use CT dose index, CTDI. Speaking about the entrance skin dose, it is the dose which can be directly measured on the patient surface when X-ray reaches the patient. So we can measure it by, for example, using TLD dosimeters, or we can also evaluate entrance skin dose by using, for example, this formula. It's not the only one formula available, but it's one of the possible options. And no matter if we evaluated the entrance skin dose by this approach or by direct measurements, we can say that as a rule of thumb, the fetal dose can be conservatively estimated as roughly 15% of the entrance skin dose for fluoroscopy and radiography. In general, this approach, once we are using the normalized dose values, is based on some mathematical formula. We have some normalized values, no matter CTDI or entrance skin dose or air kermas or whatever is available from the publication, and some correction factors which must be applied in order to convert this normalized dose values to our specific dose values, which are applicable for our particular examination. And here there is a I cannot really call it disadvantage, but something which you have to have in mind once you're applying this approach is that you should take care which parameters of the examination were used in the study you're using to calculate the fetal dose. So for example, it can be kV. If in case of publication, the authors were using 100 kV peak in CT examination, and they did not provide the option to convert their approach into more generic approach, then you only can use this formula for 120 kV. The same is applicable for gestation age. If the study was performed on the early gestation age, meaning the first trimester most of the time, then you should not use this formula for patients during their second and third trimester of pregnancy. Also, you have to have in mind which kind of examination was investigated during the study. For example, here there is a specific surgical treatment of the hip. It can be lung examination or abdomen examination. So be careful once you're applying this formula. You should be sure that the conditions of your particular study or examination are the same as were used by the researchers. And here I just mentioned 3 or four papers actually. Some of them are from the group of Professor Demiladakis, who was and still very active in this field. And one of the paper from Erin Angel, also very well known in this field. So yeah, you definitely can use this approach. It's straightforward, it's relatively easy to be applied, but please be careful about the parameters. If you want to be more generic, if you want to be specific to what you have in your hospitals, then you can either use measurements or simulations. And speaking about the measurements, you can use few types of dosimeters. The most commonly used in medical dosimetry is TLD, which was nicely advertised during the break. So TLD dosimeters, they have various shapes and sizes, easy to use. As a disadvantages, I probably should mention that one would need an oven and analyzer to, oops, now it's gone. I'm sorry, for some reason the video started. Yeah, now it's back. Okay, thank you. So you would need some hardware. And also such measurements are quite time consuming. So imagine you have to position all of the dosimeters inside of the phantom, then you have to take them out, you have to have in mind the positions, you have to warm them up to read out the curve, and prior to the measurements you also have to calibrate them. So overall, it's quite time-consuming. What else you can use? Instead of TLDs, you, for example, can use Mosfet decimators. They're also small in size, and the biggest advantage from my point of view that they provide the direct readout, the dose readout. So you perform the measurements and you immediately see the dose values. As a disadvantage, you have an upper dose limit, so roughly 200 grays. Above this limit, these dosimeters cannot be longer used. And also, since they have this tiny little wires connected to the dosimeters to read out the signal, you hardly can use them in patient cases directly to perform the measurements in patients because they produce artifacts. But in phantoms, definitely yes. And yeah, as I already kind of mentioned, that you can perform such measurements either in patients, mainly on the surface, so you hardly can place the dosimeters inside of the patient, at least not in vivo studies, and anthropomorphic phantoms, of course. Speaking about anthropomorphic phantoms, they are physical objects simulating human anatomy in various sizes and different ages. They are formulated in a way to represent different tissues, such as soft tissue, bone, lungs, brain, and etc. They are usually manufactured in tiny sections, and in each of the sections or slab, you can insert TLD or Mosfet decimators to measure the dose absorbed by a particular organ. And I wanted just to show you two groups of such phantoms, although a bit more available on the market, but these two families are the most well-known and they are commonly used in medical dosimetry. So these two phantoms are Randa phantoms, adult male and adult female, and this is a Circe family from Atom group. They have phantoms from adult male and female down to newborn. And if we want to use one of these phantoms as a pregnant phantom to represent the pregnant anatomy, we should slightly modify them. And for example, for the first trimester of pregnancy, of course, you can use just unmodified female phantom. But then later in second and third trimester, you should use some extensions. Here, for example, there is a picture from, again, John Demiladakis and his group. The study was performed in the Institute of Creta. And here you can see that it was an adjustment, some additional soft tissue equivalent material on the top of the female phantom for the second trimester and the whole replaced slab for the third trimester. And the same way, you just position dosimeters in this location where you assume your uterus was located, and then you perform the direct measurements. Of course, it's not necessary to have so specific customized phantom. You can also be quite creative. So there are, for example, 2 studies which you can easily find, and one of them is using the gelatin bolus instead of the extension rings, which is very easy to cook, super cheap, yeah, easy to use. And this is another study where the authors were using the beach ball filled with water, also as a replacement for tissue equivalent material on the top of the standard human anatomy. So, yeah, you can select one of these options if you want to perform the measurements in your lab. What you should have in mind that such measurements are not patient-specific. Of course, the anatomy of the standardized phantom is not the same as the anatomy of this particular patient. Therefore, you should be aware of that the measurements won't be super accurate, so they will not be patient-specific. Now we will switch to the third option, the Monte Carlo simulations. And speaking about the Monte Carlo simulations, it's a big group of computational methods. They're used not only, of course, in medical imaging, they're used everywhere nowadays. And in medical imaging, surprisingly, they are now considered to be a gold standard. 5 years ago, I would still say that the measurements are our gold standard, and we always have to rely on the measurements. Nowadays, the accuracy of Monte Carlo simulations, once they are validated, is very good. So once we do the Monte Carlo simulations, we have to consider 3 main components: the object, so our patient most of the time, X-ray source, and the geometry, the distance between the first one and the second one, and different collimations and so on. So first of all, I will say a few words about the object for Monte Carlo simulations, what we can use as an input for our study. We can use either virtual phantoms, and there are plenty of them available. I will speak about it a bit. And also we can use the patient images, the DICOM images, especially for CT, for example. Speaking about the phantoms, I would really recommend you, if you're interested in this topic, to read the nice book from Professor Xu, or if you want to have a short introduction to this topic, although the short is about 20 pages, but it's a very nice article, also from Professor Xu, and he described all kind of virtual phantoms available nowadays, and starting from the very old, the first generation of the phantom, and the history, how these phantoms were developed, and so on. So, nice paper to read. As I said, there are several generations of virtual phantoms. The oldest one, which is called, and still called, stylized phantoms, you can see one of the representatives here. Their organs are quite simple. They are described by equations such as cylinders, spheres, cones. So really simplified anatomy, let's say, comparing to the human anatomy. But they were designed in the middle of 60s. The first still well-known family of such phantoms is called ORNL phantom family. And in 90s, they were modified by Stabin and his colleague in order also to take the pregnant patient into account. The geometry is still quite simple, so you don't see the fetus head or, I don't know, extremities, but it's still good enough and it's easy to use such phantoms. So this is the first generation, stylized phantoms, mathematical phantoms. The second generation is called Voxel Phantoms, and they were mainly developed in the middle of 80s. Once we were able to scan, to perform the CT and MR scans of the good quality, their organs are segmented by voxels, and these phantoms are obtained from the real CT and MR images of the human. So this is the first group which I wanted to mention here. It's ICRP reference male and female phantom. And here is a part of GSF phantoms family, 3 different females. One of them is with a normal habitus, another one is slightly obese, and the overweighted one. Comparing to stylized phantoms, these phantoms, the voxel phantoms, they have much better anatomy, much more human-like. They actually have human anatomy. And it was shown that this difference in the anatomy may significantly influence the accuracy of radiation dose assessment. Next generation, the newest one, I would say, it's called BREP phantoms, or boundary representation phantoms. Comparing to stylized phantoms, comparing to voxel phantoms, the organs of these phantoms are represented by meshes, and they can be easily or relatively easily deformed, extended, rotated, and so on. So it's a mathematical procedure which can be applied to the phantom in order to get slightly modified phantom. And that's the reason why there are so many of such phantoms available nowadays, because the modification does not cost so much effort. So nowadays there are plenty of such phantoms available on the market, pregnant patient on different stages, also movable phantoms, phantoms with vessels, and so on. As I said before, one can put images as an input for our Monte Carlo simulations. Why I cannot now scroll through the presentation? Okay, now I can do it again. Okay, so comparing to the phantoms, of course, if we use the patient images, they are much more patient-specific. It's our real patient, and we can take the maternal habitus into account. We can also take the shape and the position of the fetus into account. As a disadvantage of such approach, the organs are not delineated, so we should manually segment the position of the conceptus in the maternal anatomy, and also we cannot use the
So it seems we have a problem with the video from Natalia. So we are trying to check with her if she has problems with the connection. Please be patient. Okay, Natalia is trying to connect again. We hope we can solve this issue soon.
I'm not sure because it seems like my microphone is on, my camera is also on, but I'm not sure if you can.
We can see you and hear you again.
Perfect.
Okay. So you have 5 minutes.
Okay, thank you so much. I will continue from the same slide. I hope that you could hear me before. So yeah, speaking about the images of the patient. So as I said, the organs are not delineated, so we have to perform the segmentations. And also if we have the images outside of the region where we can see the fetus, we of course cannot use them to evaluate the dose to the fetus from Monte Carlo simulations, which is again not an option, for example, for such modality as fluoroscopy, because we do not expose fetus by purpose in order to get the images. We expose the region where we want to perform the procedure. So in such cases, we definitely need to use virtual phantoms. Okay, now we will switch to the X-ray source. We, of course, need to model the X-ray source in our Monte Carlo simulations. We either can, we should take into account the energy spectra, the MA, the automatic exposure algorithm, if this one was applied, and we also should know which filtration is implemented in our system. We also should consider modality-specific parameters. For example, we should take pulse rate and collimation in case of fluoroscopy into account, and we should take focus and total beam widths once we are simulating for CT modality. Geometry. For geometry, it's definitely important, for example, for fluoroscopy to take the distance between the source and the subject into account and the different angles which we were using in our real study. In case of CT, it will be scan length, for example, and the trajectory, whether it was spiral or sequential, because it might influence, and it definitely will influence, the dose distribution in the phantom or patient's body. Of course, once we know geometry, we know the subject, or we use phantom instead of our patient images, and we know the geometry. Now we should put all of these components in some computational environment, because of course we need to perform calculations somewhere. And as a computational environment, we can use, this is the most commonly used probably nowadays code, which is called MCNP transportation code. And this is very, generic code, which can be used for any kind of particles and for generalized geometry, which makes it very useful because we can use it for radiography, for fluoroscopy, and for CT, for any kind of modality. But the drawback or disadvantage that one really needs to know how to code, because it's not really intuitive, it's not graphical user interface, so one really needs to know how to program in order to use it. But otherwise, it's really great too. If you want to have something more simple with graphical user interface, I would recommend to start with the code from Finland. It's called PCXMC. It is so far available for radiography and fluoroscopy simulations, and it has the library of phantoms, which can be slightly modified in a size. As another option, if you don't want to perform your own Monte Carlo simulations, you can use one of the available calculators, which are also based in the end on Monte Carlo simulations, but you don't have to perform them by yourself. And this is the oldest tool, which is still on the market, easy to use. It's called Impact CT from UK. One can just modify the data in order to make it closer to your own system, to your own CT system in this case, because this tool is only, it only allows you to calculate the dose distribution from CT examinations. The phantoms are relatively old. It's, as you can see, stylized phantoms. And because of that, you cannot use them for second and third trimester, because they only have the representation of the standard female, non-pregnant female. And as I said, it's only for the CT modality. Another tool which I would strongly recommend, it's from the group of Professor Demilakis, who will present after me, so you can also ask him some questions. This is a wonderful project. It's a part of the CONCERN research project. And as an aim of this part, the researchers developed a software which allows you to evaluate the fetal dose from all possible modalities, plus also from the occupational exposure, so the exposure for workers during the fluoroscopy-guided procedure. You can find it on this website. It's free of charge. It's web-based. The only one, I'm not even sure if it's a disadvantage, but it's sometimes tricky to use it if you ask it to be used by the radiographer or radiologist, because the software would require to provide such parameters as CTDI free in air, beam collimation, and CTDI normalized by 100 ms. And sometimes it's tricky for the radiographers or radiologists to provide such information, but in general, I would really suggest to try it. And also my group, we developed the another tool, which is called Fetal Dose Org. It's also a web-based tool. So we aimed actually to create something which can be used by clinicians. So as soon as you see the patient dose report, you can directly use the tool. You don't need to have any additional information. And it is also based on the relatively most modern phantoms. So it's RPI phantoms from New York University. So this is how it looks like. It's very easy to use it. You just have to provide gestational age in months. You have to put the KVP here, CTDI from the dose report, and this is optional parameter, maternal perimeter. You can have it or not. Then you press calculate, select the region, first select the region and then press calculate, and then you get your results. So as I said, really easy to operate, free of charge, web-based, also validated, which I think is very important part. But as a disadvantage, we did not consider any other modalities except CT. So in order to conclude and somehow summarize my talk, I would like to underline once again that X-ray-based procedures might be dangerous and represent a significant concern for both, for mother and also for the caregiver. The concept of dose should be evaluated in order to allow us to operate with some numbers and assess the risk. Some normalized dose metrics can be used, Monte Carlo simulations can be used, and measurements can be used for this purpose. And such calculators, as I have shown before, are also quite useful to assess the dose which was received by conceptus in the X-ray studies. So thank you very much. I'm available for the questions, most probably in chat. Hopefully that connection will stay stable.
Okay, thank you, Natalia, very much. The questions will be summarized at the end of this session. So let's move to the next talk. It's my honor also to present now Professor John Danielakis. He's professor and chairman at the Department of Medical Physics, University of Crete, and director of the Department of Medical Physics of the University Hospital. He's vice president and president-elect of the International Organization for Medical Physics, and his main research interest, have been focused on medical radiation protection and dosimetry. His talk is focused on radiation exposure of pregnant patients and pregnant employees in imaging departments, an overview actually of regulations and recommendations. So John, the floor is yours. Thank you.
Thank you, Eleftheria. I hope you can hear me. It is quite a pleasure for me to give a talk. Thank you for your introduction. Thank you for giving me the opportunity to discuss with the audience this topic, which is very important. It is about regulations and recommendations. So just to be sure that we are all on the same page, regulations are rules made by the authorities, and recommendations are suggestions of a committee or a group of experts on what is the best thing to do. Okay, so let's start from regulations. So a few years ago, the European Commission decided to simplify legislation by integrating relevant directives into one directive, the European Union BSS. And Article 62 of this BSS is on special protection during pregnancy and breastfeeding. Well, it's important. I will read it. It's important mainly because it is a law in all European member states, and therefore we need to know this law. So the first paragraph is about accidental exposures. In fact, member states shall ensure that the referrer or the practitioner, as appropriate, inquire as specified by member states whether the individual subject to medical exposure is pregnant or breastfeeding, unless it can be ruled out for obvious reasons or is not relevant for the radiological procedure. In other words, screening is needed to avoid accidental exposures. And the second paragraph is about intentional exposures. If pregnancy cannot be ruled out, and depending on the medical radiological procedure, in particular if abdominal and pelvic regions are involved, special attention shall be given to the justification, particularly the urgency, and to the optimization, taking into account both the expectant individual and the unborn child. Third paragraph, in the case of breastfeeding, individual nuclear medicine, depending on the medical radiological exposure, special attention shall be given to the justification, particularly the urgency, and to the optimization, taking into account both the individual and the child. And the last article, the last paragraph of this article is about awareness, to increase awareness through measures such as public notices in appropriate places. Okay. In fact, there are two problems associated with the pregnant patients requiring imaging examinations with ionizing radiation. A number of physicians easily recommend termination of pregnancy for women exposed to diagnostic X-rays. This article is a very old article, but there are newer articles such as this one. In this study, knowledge of radiation risk in pregnancy was assessed by asking questions to radiologists, residents, technologists, and the authors found that a significant proportion of the participants suggested medical termination of pregnancy as an option. The other problem is that a number of physicians do not perform X-ray examinations on pregnant patients, even if this is needed. And despite the fact that the radiation risk for childhood fetal cancer is negligible, it's only 0.06% if the embryo or fetus dose is 10 milligram. Richard, Professor Wakeford, provided detailed information about doses and risks. So this is the other face of the problem. Very quickly, Natalia provided important information about doses and how to calculate them. So very briefly, the dose to the conceptus from abdominal X-ray examinations is relatively high. So can be for X-ray examinations, can be from about 2 or 3 milligray to about 20, 25 milligray. Of course, these are average values, just to take an idea about the level of doses, because as we all know, the actual dose from an examination varies very widely, depending on many factors, such as exposure parameters, the geometry, the software used, and so on and so forth. And the dose to the embryo, to the unborn child, from nuclear medicine examinations, again, Sigri gave us a lot of information about this topic, nuclear medicine, and again, just to, as a general rule, the dose, the conceptus dose from nuclear medicine technetium examinations are lower than 10 milligray. So and using smaller activities, smaller administered activities, and longer imaging times, we can reduce the absorbed dose to the conceptus. Okay, this is brief but important, I think, information. There are several studies on physicians' perception of risk associated with diagnostic X-rays, and all of them show that physicians perceive the risk associated with these examinations to be unrealistically high. This can lead, of course, to unnecessary terminations of pregnancies. And this is another article, a survey which reveals that there is a lack of knowledge of fetal dosimetry in the imaging of pregnant women suspected of having pulmonary embolism. So the main question is, how can we avoid accidental irradiation? This is a crucial question. And we can move from regulations to recommendations. Then this is a recommendation from ICRP. It's about screening, how to determine pregnancy before irradiation, and ICRP states that investigation of the reproductive status of a young female prior to X-ray imaging is needed, and it is prudent to consider as pregnant any young woman presenting herself for an X-ray examination at a time when a menstrual period is overdue or missed, unless there is information that precludes a pregnancy. Determination of pregnancy, okay, screening, it's very important for all departments, radiology departments, nuclear medicine, radiotherapy, to define their policy on how to screen pregnant patients. This is very important to avoid accidental irradiation of pregnant patients. So we can use several methods. Verbal questions, discuss with pregnant patients, forms, so in writing, also performing pregnancy tests when it is needed. The important message here is the departments need to define their policy. And of course there are problems. Healthcare personnel is not trained to question patients about their pregnancy status. This is something that needs to be addressed. This is a real issue. And there is no policy with 100 guarantee of detection. Posters. Using posters may help to convey to individuals from the need to it's very important to provide information to patients. So the wording is really important. So please inform the staff before your examination. This part of the sentence is very important. Before your examination, if you think, not if you are pregnant, if you think you may be pregnant. And again, using pictures may help to convey the message to people. We should not forget that there are also immigrants, or there are people who don't understand our language, so we need to provide information also to these patients. Do we know the frequency of these accidents? Do we know the frequency of abortions? Difficult questions. So Kimberly has already provided some information about trauma patients unaware of pregnancy. As far as I remember, the percentage was 11%. There are also other articles. 1% of women of childbearing age who underwent abdominal radiographs were unknowingly pregnant in their first trimester, and 2.9% of trauma patients were pregnant, and the unidentified pregnancy rate was 0.3%. What about the abortions? This is more difficult. So Natalia already said something about CONCERT, which is an acronym. It's in fact a research. It was a research project, ended a few years ago, And one of the objectives was to collect information about accidental and intentional irradiation of pregnant patients using a questionnaire. We used a questionnaire to get information. So this was a question to obstetricians. How many pregnant patients exposed accidentally to diagnostic X-rays visited you during the last 12 months to ask advice about the biological effects of radiation to the conceptus? And the results were rather striking. 63% said that from 1 to 5 pregnant patients exposed accidentally to diagnostic X-rays visited them during the last 12 months to ask advice about the biological effects of radiation to the conceptus. So the percentage is not low. And what constitutes childbearing age? Simple question? No, it appears it is not so simple. Question to interventional cardiologists. What is the minimum and what the maximum age you use for questioning a patient about pregnancy? And about 43% did not include minors in the age range, and not negligible percentage did not, 16% did not include patients older than 40 years in the age range. This was a question to radiologists. How many pregnant patients are subjected to diagnostic X-ray examinations in your department every year? 0%, 0 patients, 46%. In other words, almost 50%, half of radiologists said that they don't see pregnant patients in their department. And why? What makes referring physicians reluctant to send pregnant patients to X-ray imaging departments even for extra abdominal exams? Lack of knowledge about fetal dosimetry, the main reason, and possible legal consequences. These two reasons. Lack of knowledge about fetal dosimetry, possible legal consequences, and the same questions to cardiologists, same answers. Lack of knowledge about fetal dosimetry, possible legal consequences. Same questions to the obstetricians. So they all agree that they are reluctant to send pregnant patients to X-ray imaging departments for these two reasons. Lack of knowledge about fetal dosimetry, possible legal consequences. Okay, justification. I think we all know that we need to balance doses and risks, and conceptus risk is a function of two parameters, conception age and conceptus dose. So we need to answer two questions to estimate the risk, what is the conception age and what is the estimated conceptus dose. And a detailed dose assessment is not needed if the conception age is less than 2 weeks, the all or nothing effect, and when the conceptus is low also. If the conceptus dose is low, a detailed dose assessment is not needed. I will come back to that later and define the word low, how low should be the conceptus dose in order to avoid a detailed dose assessment. First few words about justification. I think it is important to know that conceptus dose depends on the size and position of uterus. So the conceptus dose from a chest compute tomography during the first trimester is negligible. However, during the third trimester might be high. This is something we medical physicists, referring physicians, radiologists, nuclear medicine physicians, we should always have in mind that justification in the case of pregnant patients depends on the stage of pregnancy. Accidental exposure of pregnant patients occurs during the first post-conception weeks. Patients realize that are pregnant few days or weeks after the examination, and the first question is, what is the dose received by my baby? what will happen to my baby? Is there any risk? And its patients are not as and referring physicians alike. They are scared sometimes, and proper communication is very important. But to communicate properly, we need to know one thing or two about those levels, conceptus dose levels. So ICRP and national and other international organizations and committees, I think they all agree that conceptus doses below 10 milligray are relatively low, means that installation-specific measurements and calculations of fetal doses may be necessary if fetal doses are suspected of exceeding 10 milligray. If they are lower, then detailed determination of conceptus dose is not needed, especially if the dose, if we are talking about extra-abdominal examinations, because it is obvious that when the embryo or fetus is exposed primarily, then the doses are higher. If for extra-abdominal examinations, the doses are lower. So this is one point, that installation-specific measurements and calculations may be necessary if fetal doses are suspected of exceeding 10 milligray, and conceptus doses below 100 milligray should not be considered a reason for terminating a pregnancy. Above 100 milligray, then abortion might be considered, especially if the exposure took place during the first trimester, when the embryo is more sensitive to radiation. So this is a good point to keep in mind. And these two dose levels, 10 and 100 milligray, in order to manage pregnant patients properly and in order to communicate with patients, their relatives, referring physicians properly. And dosimeters and medical radiation physicists should report those results properly, include in the report a description of the method used to estimate dose, a table presenting exposure data, a table presenting conceptus dose estimation, and a brief paragraph on biological effects. I think this is very important information to be communicated. This is really needed. There is always a chance that a woman will give birth to congenitally malformed children regardless of any exposure to radiation. This is something that we need to inform patients. So the pregnant patient needs to know that there is a chance that the baby can be, there is a possibility about 3% or 4% that she can give birth to congenitally malformed child regardless of radiation. Informed consents, also important, especially, of course, this is for intentional exposure, so pregnant patients should sign a form after they are being informed. And examinations must be optimized. Dose optimization is a very important fundamental principle of ICRP, as you know. This is a rather big topic. I don't have time to provide more information about this. This is just an example, parameters that affect CT dose. There are so many parameters, exposure parameters, collimation, scanning length, reconstruction, slice width, automatic exposure control, and other dose reduction tools. Also in interventional radiology, many factors, many parameters affect conceptus dose. So we need to know these parameters in order to keep the dose as low as possible and at the same time get the information needed in order to make the necessary diagnosis. And this slide shows some practical actions to control dose to the patient during fluoroscopically guided procedures. So for intentional exposures, this last step, the performance of examination, for this last step, optimization is really important. Well, I will say a few things about pregnant employees working in imaging department. ICRP publication 84 states that the working conditions of a pregnant worker after the declaration of pregnancy should be as such to make it unlikely that the additional dose to the conceptus will exceed about 1 milligray during the remainder of pregnancy. Again, this is for pregnant workers. This is the recommendation of ICRP. The same has been somehow adopted and included in the European BSS, so 1 milligray during the remainder of pregnancy. And this is also very important, voluntary declaration of pregnancy. So a female worker should, in becoming aware that she's pregnant, notify the employer in writing in order that her working conditions may be modified if necessary. And this is also important, dose monitoring. In my hospital, in the University Hospital of Crete, we use conventional dosimeters provided by the Greek Atomic Energy Commission. And in the interventional suites, we also use real-time dose monitoring lately. That makes it easy for staff to monitor and track radiation exposure during their shift. So real-time dose monitoring, our first experience, because this is a new resource for us, my first experience is that this real-time dose monitoring is really helpful. And in case of pregnancy, we issue supplemental dosimetry, which means that the standard whole body badge is worn outside the shielding and the separate badge for fetal monitoring is worn beneath the shielding at waist level. So 2 dosimeters, and a potential problem with personnel wearing 2 dosimeters is that individuals can become confused sometimes in wearing them. So one way to minimize this confusion is to color code the dosimeters. So this is the dose monitoring topic is important for us, for occupational dosimetry and for personnel. Conceptus dose estimation tool, Natalia already provided information about tools. There are some tools, and one of them is code. And we have recently uploaded on our website other tools also about AutoWet, automated calculation of water equivalent diameter, X-ray spectrum generator for Monte Carlo dosimetry, and the most important tool perhaps is coming. This is a work in progress, personalized computed tomography organ dose estimation tool based on impact MC and personalized dosimetry. So this is within the Medirad research project framework. So in mid 2021, we are planning to upload and will be free of charge, will be free to use. Okay, so main messages to take home. We need to avoid accidental irradiation, and this means that investigation of the reproductive status of young patients prior to X-ray imaging is needed. All departments, relevant departments, nuclear medicine, diagnostic radiology, interventional radiology, radiotherapy, need to define a policy, to have a policy on how to screen pregnant patients. Those conceptus dose estimation is needed, especially for abdominal X-ray studies and nuclear medicine examinations. But we should always bear in mind that situations that may lead to radiation doses higher than 100 milligram are very rare, especially in diagnostic radiology. And this means that abortion due to these examinations is not justified in the vast majority of cases. I would like to thank you for your attention, and I will be happy to answer your questions if I can.
Okay, thank you, John. Thank you very much. We have only one last presentation in this session of the first day of the winter school. The questions will be in 20 minutes or something like that during the discussion. So the next presentation is a pre-recorded presentation about the possible effects of space radiation exposure on the reproductive system and fetal development. It's going to be given by Professor Hasuda, who has been working for more than 20 years in the field of radiation dosimetry and health risk analysis. He's one of the authors of the ICRP publication about radiological protection from cosmic radiation in aviation, and he also worked a lot about the public dose assessment after the Fukushima accident. Currently, he contributes a lot to the activities of Working Group 11 and 12 of EURADOS. So let's hear. Any questions can be put at the Q&A, and they will be answered by Professor Hasuda. Thank you.
Good evening. My name is Hiroshi Yasuda, Hiroshima University, Japan. I've contributed to the work of Working Group 11 for high energy radiation field for more than 10 years, and also joined occasionally discussions related to retrospective dosimetry in Working Group 10. I'm very pleased and honored having a chance of giving a lecture this time for the EURADOS Winter School. I appreciate the organizer of the school and the colleagues of Working Group 11, particularly Marco Carazana, André Plock, François Trompier, and Jean-François Potelier-Depot for their encouragement. From now, I'm talking about possible radiological effects of space radiation exposure on the reproductive system and the fetal development of astronauts involved in future interplanetary space missions. My talk can be separated to two topics. The former one is about possible space radiation exposure and its biological effects in future interplanetary missions, and the latter one is about relative biological effectiveness, so-called RBE, of high LET particles of space radiation, focusing on the reproductive system and the embryonic and fetal development. So let me start the first topic, possible space radiation exposure and the biological effects in long-term interplanetary missions. As you might know, there are already concrete plans of deep space exploration in some countries. In the United States, NASA has a plan composed of 3 phases. The first phase is mission to the moon, and a second phase is to construct an operational system for the Mars mission, and the third phase is a journey to the Mars system. The period of a mission in the first or second phases is expected to be few months. It would never exceed 1 year anyways. In these phases, the astronaut would construct some facilities on the lunar surface to harvest some precious elements, such as helium and oxygen, from the lunar soil, and also construct an operational base for the next phase mission to the Mars system. In the third phase for the Mars mission, the period of the mission would be much longer. In the plan of NASA, it would take 2.5 years, about 6 months each for forward and backward flight, and about 500 days more for exploration on the Mars surface. In those interplanetary missions, one of the highest concerns is space radiation exposure and that risk on the health. In the outer space, we cannot avoid being exposed to the energetic nuclei, such as protons, helium ions, etc., and those secondary radiations produced by those primary particles, such as neutrons. Beyond the Earth's magnetosphere, the major source of space radiation is galactic cosmic rays, so-called GCR, that are composed of high-energy charged particles such as protons and heavier ions, including helium-carbon ions. The GCR particles have a broad range of energy, up to 10 GeV per nucleus. It's very energetic. But on the ground, even at the aviation altitude, we are protected well by the thick atmosphere, so we don't need to worry about such exposure. An energetic particle of GCR, mainly a proton, strikes the atom nucleus in the air and produces many hadrons such as pions, neutrons, etc. Those hadrons also produces necessary radiation, secondary radiations, and make an extensive cascade of ionizing radiations. Most of them, however, do not reach the ground. While in the outer space, the GCR particles could easily enter the spacecraft and then the body of an astronaut. As a result, their radiation doses during a space mission could be significantly higher than those on the ground. This table shows the assessed bone marrow dose rates received by the astronauts who are involved in the low Earth orbit (LEO) missions performed by NASA in the 20th century. You can see that daily observed dose was in the range of 0.2 to 2 milligray per day. This level is comparable with the yearly observed dose on the ground. I should note that these dose records of the LEO missions do not involve the contribution of a solar particle event, so-called SPE. The SPE emits a huge amount of particles, mainly protons, accelerated by a solar flare or coronal mass ejection in a short time. In future interplanetary missions that will go beyond the Earth's magnetosphere, the SPE particles could bring a severely high dose exposure to the astronauts. This graph shows predicted doses of selected organs as functions of the thickness of aluminum shielding for a hypothetical SPE, which is comparable to the largest SPE known as the Carrington event. It was estimated that the skin dose and the island dose in the interplanetary space environment could reach 10 gray equivalent under thin shielding, like a space suit used for extravehicular activities. Even the bone marrow dose could exceed 1 gray equivalent. It's significant. So these data suggest that effective shielding will be crucially important for protecting the astronauts from the radiation hazard in future missions. Actually, space agencies, NASA and ESA and JAXA, are responsible for keeping the individual doses of astronauts below the dose limits established by the authorities. It's entropy in this case. This table shows the recommended dose limits of deterministic effects for LEO astronauts. For the period of whole carrier, the dose limit of islands is given as 4 gray equivalent, and the limit of skin is 6 gray equivalent. The limit of bone marrow was significantly smaller, that is 0.5 gray for 1 year, because this organ is very radiosensitive. So here in my talk, I'd like to emphasize that effects of space radiation exposure on the reproductive potentials of astronauts have not yet been considered by those authorities. This might be reasonable for the LEO missions, since the dose levels are quite low anyways. But in future long-term interplanetary missions that will take more than 2 years, I think that this matter will have a priority. It is natural to select a young couple of male and female astronauts in such a long mission so that they could enjoy the long journey, like a honeymoon, literally. In such a situation, we cannot help but be concerned about the effect of space radiation exposure on their reproductive functions and embryonic or fetal development. This table shows the threshold doses of acute exposure for 1% incidence of sterility for testes and ovaries after whole body gamma ray exposures. According to these data, it would be unavoidable for male astronauts to have a temporal sterility because the threshold dose is quite low. Female astronauts might also have sterility due to the additional exposure from a large SPE. Regarding the embryonic fetal development, the threshold doses on embryo lethality and those for malformations are relatively low, small values. So I'm afraid to say that it would be very difficult to achieve their healthy growth, embryonic or fetal growth, in the interplanetary space environment. However, those threshold data were given for low LET radiations such as gamma rays or X-rays. In the outer space, the astronauts will be exposed mainly to high LET particles such as heavy charged particles and the neutrons. In the previous figure shown here, on the predicted SP dose, the dose was given as gray equivalent, which was the RB weighted observed dose. Then the value of RB, which is given as 1.5 here, we need to confirm that this RB values appropriate for the reproductive system or embryonic or fetal development before talking about the concrete plan of the interplanetary mission. So the question is this RB value appropriate for the reproductive system or embryonic or fetal development? So let's move on to the second topic, relative biological effectiveness, RBE, of high LET particles with regard to the reproductive potential. As you know, there are several types of ionizing radiations that have different qualities in regard to the energy transfer patterns to the material. This figure shows the illustrated patterns of energy transfer to human cells of 3 radiations, 1 MeV gamma rays, 1 MeV neutron, and 1 GeV ion. So you can see the gamma rays or compton electrons give the energy to the tissue very uniformly, but the first neutron or recoiled proton deposits the energy along the track of the recoiled proton. So in case of a high energy ion, the energy deposition is very restricted to the path of the track. So the deposition density, ionization density, is quite high. Such a different pattern of energy transfer is generally evaluated with the linear energy transfer, so-called LET. So the LET is defined as the energy transferred from a radiation to the material per unit length of the track. Then a higher LET particle could cause more complex damage of DNA and thus induce a severer biological effect with a unit dose. The relative biological effectiveness, RBE, is defined as the ratio of the dose of a higher LET radiation in respect to that of reference radiation, usually gamma rays or X-rays, required by those radiations to cause the same level of biological effect. This definition is expressed with equation 1 here. Then in a mixed field of low LET and high LET particles, the total absorbed dose is calculated as the sum of the dose of the low LET radiations and RB weighted dose of the high LET particles. So in general, the LET dependency of RBE can be shown with the curves shown here, though the level of RBE values could change depending on various factors. The RBE value would be almost unity up to around 10 keV per micrometer of LET, and then increase with LET up to around 100 keV per micrometer, and then decrease with LET, probably because the lowering efficiency in damaging DNA. So let me explain more about the meaning of RBE using a graph. So you have dose LL here as the absorbed dose of low LET reference radiation for a certain level of severity, while you can obtain dose HL here as the dose of high LET particles for the same level of severity. Then RBE can be calculated as a ratio of DLL to DHL. We should be careful because the RB value can change depending on the dose rate, particularly the dose rate of the low LET reference radiation. So if you did experiment of the low LET radiation with a higher dose rate, the curve would shift to the left. As a result, the RBE value would be smaller. The RB value also changes depending on the severity in respect. In this graph, you focus on the higher damage. The RB value would be smaller, as you can see. Let me repeat that. Even for the same combination of two radiations, higher LET radiation and the reference radiation, the RB value could considerably change due to the conditions such as targeted tissue or organ, biological endpoint in respect, ionization density of the particle, and the dose rate, etc. Okay, so with this background information, let's look at the reported RBE values regarding reproductive potential. First, let me show the data for male reproductive organ, that is testis. This table shows RBE values, selected heavy ions and neutrons for spermatogenin killing in mice. You can see relatively low RB values less than 3 for energetic heavy ions, while higher values were seen for neutrons. Next organ is the female reproductive organ, ovary. This table shows RB values of selected heavy ions and neutrons for oocyte killing in mice. It should be noted that low RB values around 0.4 were observed, which implies a different mechanism of radiological response of ovary compared to other organs. The next table shows the RB values of protons and the selected heavy ions for embryonic or fetal development. Generally lower RB values, less than 2, were obtained for those ions. One exception is for iron, but in this experiment, the Medaka fish was used, so I think the mechanism of the biological mechanism was different. The last table shows the REB values of neutrons for embryonic or fetal development. So you can see a higher, significantly higher value of RBE for those neutrons compared to those for heavy ions. So according to this data, we could roughly say that the RB value of 1.5 for space radiation is appropriate for heavy charged particles. But I'm afraid that it would underestimate the effect for neutrons. The high values of neutrons suggest that we need to make the shielding design the most carefully for the astronauts who would stay long on the Moon or Mars. This illustration shows the typical habitat structure where they would probably stay. The inside of the structure would be like this. So such a structure is expected to work well to shield the primary ions, mainly protons, but nuclear reactions like this of those ions would produce many secondary radiations, including neutrons. So it is concerned that the RB-weighted dose would not be reduced so effectively with this structure. If so, we might need to add additional shielding of a hydrogen-rich material like polyethylene to stop neutrons. So this issue should be investigated in more detail and solved in the planning process of the first interplanetary mission. So let me summarize my talk. The deterministic effects of space radiation exposure on the reproductive potentials have not yet been considered in the current framework of radiological protection for astronauts, but I think this issue will be carefully considered in the planning process of future interplanetary missions. In parallel, we need to recognize that the RB values employed for high-energy particles of space radiation are not stable. They could notably change depending on some conditions such as particle energies and dose rates, as well as biological endpoints in respect. Then it is desirable to perform more intensive studies for achieving selection of the most appropriate RB values in correspondence to possible exposure scenarios during the interplanetary mission. That's all. Thank you for your attention.
Okay, so thank you very much. Thank you all the speakers of this session. So now I can use some of the questions from the chat and the Q&A chat to John and Natalia, because the other questions that are addressed to Hiroshi maybe can be sent through the chat option only. So one question maybe to John. John, are you still hearing us? Is there any European directives according to ICRP 84 or plans for this? Okay, John, are you still with us? No. Natalia, are you still with us? Maybe we can start with your questions. It seems that there is a question on the chat about the Mosfet detectors. Can they be used to measure scatter radiation, or are they recommended to be used only in the primary beam? Okay, John, hi. Can you hear us?
Can you hear me? Hello?
Hello? Hi, can you hear us now?
Hello, can you hear me?
Yes.
Okay. Now I can you can hear me and I can hear you.
Okay.
So, yeah.
So there was a question about if there are any European directives based on ICRP 84 or plans for developing something like that.
Yes. I think I have already answered that question.
Yeah, but maybe you can share your answer with us.
Sure, of course. So there is one. It is not new. It is in the radiation protection series of the European Commission. The title is Radiation Protection of Pregnant, of unborn children and infants. Again, it is the title is Radiation Protection 100. I mean, the main it's like ICRP publications and 10 numbers, so it is Radiation Protection 100, and it is you can freely download it from the European Commission's website. It is the Radiation Protection series of publications. Needs update.
Okay, and maybe another question if Natalia is not easy to be connected. So maybe another one, a more general one about the use of the tools for the estimation, for the assessment of the dose to the fetus. So there's a question about if there are any GDPR issues or similar issues when we use these web tools. If, for example, the scan without the name, but with all the rest of information. Poses any issues against this directive about the general data protection regulations?
That's a very nice question, actually. I mean, for Conceptus, those estimation tools, at least for our tool code, no, there is no any problem because we don't ask users to upload examinations or images. All they have to do is to provide data related to exposure parameters, DTI values, scanning length, and so on and so forth. But the question is really important because other tools, for example, the tool we are currently developing, CityRad, yes, you need to upload data only to calculate some body size specific parameters, and of course these data should be anonymized. We can easily as medical physicists, I think we should know how to anonymize data, and it is easy. I mean, to anonymize, to delete DICOM data. So well, this brings us to another point. I mean, why we need to get into machine learning fields and know how learn a little bit of Python programming, and then know how to use GitHub and websites like that. And then it is, believe me, it's very easy, piece of cake to download the code or write a script and anonymize DICOM data. We have done it here. We could easily produce a GUI and upload a tool to anonymize images and DICOM data so that people can use their images and examinations can upload it safely. But yeah, it's a nice, because of the machine learning tsunami, it is a very important question, and in the near future, we will be discussing this widely and frequently. I guess.
Okay, yeah, I understand. Yeah, thank you. So, Natalia, are you now with us? Can you hear us?
There was a problem with the system. I mean, they disconnected us. It disconnected us some minutes ago, so I had to do several manipulations here to reconnect.
Okay, so since maybe you can answer a small question about the position of fetus in the uterus is really important. Is a question something like that? So position of 3 months fetus is different, for example, from 9-month fetus. Is this taken into account in phantoms used in Monte Carlo simulations?
Yes, definitely we have to take it into account during all trimesters of gestation, especially during the first weeks post-conception. So all methods, I mean, at least the methods we have developed here, they take into consideration the conceptus depth and position in the uterus, means that the proper way of doing it is to perform an ultrasound examination in order to calculate the depth of the conceptus, and then this information is needed for most of the methods to calculate the dose to the conceptus accurately. So definitely it plays a major role, and we see big differences between. Obviously, I mean, this is obvious that if you don't take it into account, then don't expect accurate results.
Okay, so thank you very much. I see that there's problem of getting Natalia back, so I need to close now the session. So I would like to thank, yes, Natalia, welcome back.
Took a while to reconnect.
Okay.
I don't know, it's not really stable.
Okay, so there's a question about what would you recommend to mimic the fetus in Monte Carlo simulation when the CT does not include fetus, but there is still a need of estimation of the dose to this area, to the fetus in a realistic clinic scenario?
I would suggest to use phantom. So if fetus is not visible, so you can take any virtual phantom and to perform Monte Carlo, for instance, if you have an option, of course, to perform. But if there is no option to perform Monte Carlo, so measurements, to repeat exactly the same examination as was made for the patient, even if you don't have, phantom in your own hospital, it can occur, then you can use, as I said before, you can be quite creative. You can use, a bucket of water or any kind of cylindrical phantom and just place the decimators inside and repeat. So depending on what kind of materials, what kind of hardware you have. If you have phantom, then perform measurements exactly in the same way like the procedure was made for the patient. If you have an access to Monte Carlo code, or if, you can also use one of our tools. That's the easiest option.
Okay, thank you. And another question about Mosfet detectors. Can they be used to measure scatter radiation or only in the primary beam?
I would say that one can use them, but I would prefer to first calibrate them and see how do they respond against some well-known decimeter, just to be sure that the absolute dose is correct.
Okay, so thank you very much. With this, I would like to thank, first of all, the back service like Babs, Kirsten, and all their colleagues. Also my colleagues in the scientific committee, of course, the speakers, and all of you for your attention. So see you tomorrow. Have a relaxed and safe evening. Okay, goodbye.
Thank you, Eleftheria.
Thank you.
Thank you,
Bye.
everyone.
Thank you.
Bye-bye.
Bye.
Bye.